So, as we did last time, this is what we are going to do right now, the conduction abnormalities, and I'm going to summarize the important points of the conduction abnormalities. Basically, we started the last time the arrhythmias. We discussed the arrhythmia. What is arrhythmia? It's not a normal sinus rhythm. It can be different in rate or in rhythmicity or the impulse formation center. So this is one big chunk of the ECGs that we discussing. That was the impulse formation abnormalities. Now let's see in other topics when we are talking about a conduction abnormalities. So what does it mean? It's meaning the impulse is formed in the right place or maybe in different place, but after when we had a conducting pathways, somehow the conduction through those pathways is abnormal. So this is what we called, these are the blocks. And of course, if the impulse made somewhere, these should be propagated all over the muscles, all over the ventricles, and contract the heart. If we do have any kind of block, any kind of conduction abnormalities, for sure, the impulse is not propagated, the heart is not going to contract. This is what is making the arrhythmias. And in other areas, when we do have a faster conduction, usually we do have an accessory pathways, and that's going to give us, it's called the pre-excitation syndrome. But first, let's look at what we call as a block or conduction abnormalities. Now, generally talking, based on the severity of the block, we are talking about first degree, second degree, or complete block, as it's called, the third degree block. And by the location, as you see, we are talking about the sinoatrial block, the AV junctional block, and intraventricular blocks. Now, generally talking, what the first degree block means. The first degree block means that we do have connection between A and B point if you are evaluating the areas of the atrium or the ventricle or inside the ventricle or between the SA or in the atrium. These charge that made in one point that will propagate to the conducting pathways normally with a normal speed. So this is what the charge reaching B. First degree block means that we do have this connection. We do have a wiring between these 2 points, and this will work, but it takes longer time. So the conduction velocity is slowing down. That's a first degree block, what is so. So by meaning every charge that's made, it's propagated. So normal situation, this be rhythmic. First degree block, still rhythmic because every charge that made, it's getting to another area. So the heart works perfectly rhythmically, but takes longer time to get one point to another one. What the second degree block means? Second degree block means that we do have some block, complete block that is not conducted from A to B, such as, for example, as you see, the first is conducted normally, but the second one is not conducted. After we do have some conduction, after we don't have conduction. So this makes the heartbeat arrhythmic. This is the second degree. And the second degree AV block that you see, it has 2 different types based on the severity or based on the location. Now let's see. This is one is called Mobitz type 1. What does it mean? As you read it or you watch the movies, basically it's meaning that we do have conduction between A and B, but somehow this conduction is getting slower and slower by every revolution. And once the block is dropped, and after start everything from the beginning. So as you see here, the velocity of the conduction is slowing gradually, and one is complete block. And again, looks like there's a little rest is enough to the conducting area to be repolarized completely normally and start from the beginning and goes again. So it has some kind of rhythmicity inside this conduction abnormality. the second type of the Mobitz type 2. The previous one, as I saw here, this is called the Wenke-Bach periodicity as well, because it has some kind of periodicity. So these are two names, but I think it's enough if you remember Mobitz type 1 or Mobitz type 2. Now, Mobitz type 2 means that we do have conduction between A and B point, but the velocity of the conduction is not changing. So it was the same in the first one, the second one, the third one, but between these, we do have an unconducted block. By definition, the second degree block has only one unconducted bit between two conducted ones. So it's meaning that conducted, conducted, not conducted, conducted, that means second degree, okay? Or conducted, not conducted, 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 and not conducted. This is again a second degree block. Now, there's another type of the block that is a little bit different one, but it's difficult to distinguish between Mobitz type 1 and Mobitz type 2. This is a 2-to-1. What does it mean? It's meaning that every second bit is not conducted. So this is why the last and the first conducted bit the same. So we cannot say that the velocity is different or not. This is the 2-to-1, and you do see that it's bradycardic usually because every second one is not conducted. So this way, not every charge gets from one point to another one. This is the 2-to-1, and you have to compare. Now, why is it important, especially when we are talking about the AV block? The clinician should know whether this is a life-threatening situation or not. Mobitz type 2 is a life-threatening situation. And 2-to-1 again could be a life-threatening situation. So the physician is going to implant the pacemaker immediately into the system, especially when we are talking about later on the AV blocks. High degree block means that there are more than one unconducted bits we do have between two conducted ones. It's meaning that not conducted, not conducted, not conducted, and sometimes conducted. Now, this makes, again, this is rhythmic. So, first degree AV block is rhythmic. Second degree AV block, not rhythmic. 2-to-1 AV block is rhythmic. High degree is not rhythmic, because whenever we do have a conduction, that makes it arrhythmic. Because if we do not have conduction between 2 points, it's meaning that the lower center is taking over and you do have an escape rhythm. And once when we do have a conducted bit, that makes a little bit faster coming bit. Now, third degree blocks means that there is no connection between these 2 points. So not at all, forever. All right, this makes we do have a lower center if we had, and that's going an escape rhythm. Now, these kind of blocks could occur anywhere in the heart. Whenever we do have a pathways that conducting the charge normally. Of course, you know that we do have conduction between the nodal tissue and the atrium. These are between the A and B here in the SA node that we do have conduction. Or we do have conduction through the AV junction, and we do have conduction in the bundles inside the ventricle. Now, these are different blocks. We are talking about SA blocks, AV block, and intraventricular block. Now, one big problem, for example, in the SA block, we do not have any sign of the activation of the SA node. There is no sign on ECG. If you do have an esophageal ECG, or you place directly the electrode on the top of the heart or close to the assay, yes, you do see the spike when the assay is activated. Whatever you have only the ECG when the atrium is activated. So relatively, as you listen here, there's no sign of A, but we do see the P wave. So we have to diagnose this one based on the P's. The best one to look at the AV block, because we do see sign of the atrial activation, this is the A, and we do see the sign of the ventricular activation, that's the B, and we are evaluating the connection between these two, between the P and the QRS complexes. And intraventriculars, we are talking about the QRS shape and the width of the QRS, because that area that is has a block, that the charge goes through the muscle, so that has a muscle conduction. Now, AV block, let's go through because you already looked at it. Okay, this is incomplete when we do have the first degree, second degree, 2 to 1, and high degree as well, and the complete one, the third degree. This is how you can name them. Okay, let's see what the first degree. First degree is very simple one. We do have, you know that this is why we have to learn the different distance, the PQ interval or PR interval. This is from the beginning of the P till the beginning of the QRS complex, and that's the maximum is zero 0.2 seconds. And of course, this will depend on the heart rate. Because if you do have a faster heart rate, the PR interval is shorter. If you have bradycardia, the PR a little bit longer, but never ever exceeds the zero 0.2 seconds. So when we do have a first degree, every P gets to the QRS complex, every P followed by the QRS. However, the gap between the beginning of the P till the beginning of the QRS is longer than 0.2 seconds. This is what is called first degree AV block, and that's rhythmic. Keep in your mind that rhythmic. Okay, that's simple one. We will practice later on. We will practice. Okay, so as you see here, for example, that this is rhythmic. This is why we are starting the evaluation by looking at the rhythmicity. It will tell you a lot of things. For example, whether impulse formation or conduction abnormality or anything happening in the heart. Now, second degree AV block, that meaning that there are some P's that not followed by QRS. Very important. AV block, you have to have P and QRS. And you are evaluating the connection between these two. Okay? Mobis type 1, we said that the PR interval is getting longer and longer and longer. As you see here, what is going to happen? The PR is longer, but the P and the T distance is shortening. All right. And once that is reaching a very long way, P always inside, almost inside the T wave, that is a dropped P that's not followed by the QRS complex. Another very important one, that not only the PR is getting longer and longer and longer and longer, but as you see here, the RR interval is getting shorter. Now, this is not how you will recognize an second Mobis type 1 AV block, but it's very important when we're talking about the assay block, because we do have only in assay block the P wave. Now, if you had to diagnose, for example, the Mobis type AV type 1 AV block based on the RR or the only that you have a QRS complex, you have to evaluate how the RR is changing. Importantly, this distance, the last conducted and the first conducted R, the distance, is less than twice as the last RR interval. This you should keep in your mind. Now, this is what it's important one, and you already had this one, that's important point. But the P's, they coming regularly. Okay, that's important. The P is coming regularly. However, you will find a P that is not followed by QRS complex. Another important one, the P's are identical. All right, this is another important point. Okay. Now, all right, let's go to the second degree. The second degree is very simple one because it's meaning that the P are always the same. However, you will find a P that is not followed by QRS. As you see here, the P equal. And when you do have the gap, when there's no QRS complex here, this is exactly twice as much as the last RR interval. That's simple. 2 to 1 AV block, very simple. Every second P is not conducted. Okay, you can see P's, however, you do see some dropped P's. You should I should mention that the T is bigger than a P wave. And if you do have QRS, you have to have T wave. Don't forget it, because sometimes when we were talking about some uh, impulse formation abnormalities, and sometimes it could be you assuming that, oh, that's T should be the P wave. No, T has to be if you have QRS, and an additional wave should be the P wave that is smaller and is distinct for the T wave. Okay, that's a bradycardic, as you see, and always you do have P wave that the shape is the same. High degree blocks. Now, that's a little bit difficult to understand. First of all, most of the time, or some segment of this ECG is rhythmic. Because if we do not have conduction between these 2 points, it's meaning that the ventricle cannot be contracted. However, we do have, let's see, a system that is saving our life, and that's the nodal tissue in the lower part of the AV or inside the ventricle that's generating the own impulse. However, the rate should be less, much less, and that means that's rhythmic. So we do have escape beats, okay? And whenever a supraventricular conduction occurs, as you see here, we do have a relatively normal QRS complex, but this is arrhythmic. And this is what is called capture beat. So the capture beat is always arrhythmic, so it doesn't come in the time as an escape rhythm. However, it could happen that the supraventricular conduction and the escape bit from the ventricle hitting the same time of the ventricle. So it's meaning that some part of the ventricle was activated through the normal conducting system from a supraventricular source, and some part was activated through the escape center. So this is what is called the fusion bit. So if you are looking at a high degree block, first of all, is arrhythmic, and you do see at least 3 types of QRS complexes. One type, that's an escape bit. Another type, the capture bit, it's coming from supraventricular area. And another one, in between these two, some kind of, it's called the fusion bit. So it's not the same as an escape bit because it's altered by a normal conducting pathways activated ventricular pattern. Third degree blocks, very simple one. It's rhythmic. How can you judge it? Basically, you do see P waves and the P is coming in time, all right? However, there is no connection between P and QRS complex. You could assume that maybe the PR distance is changing and okay, it is getting longer and longer and longer, and after it's not conducted because somehow, yeah, but this is arrhythmic completely, and the RR interval constant. Maybe you could confuse with Mobis type 1, but in Mobis type 1, the RR intervals are not constant. And another thing, that basically the QRS complex is normal in Mobis type 1 AV block, because that's meaning the AV, when conducted, is reaching the bundles and giving a normal QRS shape. But here, these RR intervals are constant, and you do see very nice wide QRS complexes. It could happen that this escape center is very close to the lower part of the AV junction, and this way the QRS complex is not as wide as not a typical one as a QRS complex of the ventricular origin, but is still you do not have any connection between the P's or in the P and a QRS complex. Sometimes it's happening that, and this is another good clue, that the PR is getting shorter. Okay, the PR is getting shorter. If you do see this feeling that the PR is getting shorter and it's rhythmic, for sure is a third degree AV block. Okay, so we do have P waves and we do have a normally rhythmic QRS complexes, and that's the third degree AV block. As you see here, we do see rhythmicity, but of course, we do have a lot of P's. That is a simple one. Third degree, okay, we will solve. Now, essay block, that's a little bit difficult one. And that could be the first sign, for example, of oxygenation abnormality when the SA block occurs. Now, that meaning that we do have still first degree, second degree, and Mobius type or Mobius type, and a third degree. Now, first of all, you cannot recognize the first degree block because first degree block means that it's getting out and is getting out rhythmically, so there is no sign of on or 12 leads ECG. There is no sign. If you had an esophageal ECG and you can detect when the assay is activated and after the charge is propagated and how fast the charge propagates to the the atrium, that could be a very good clue. Now, second degree, a little bit difficult one because it's meaning that there are missing P waves. That's be very similar when we had an impulse formation abnormality. It's called the sinus arrest, when there is no impulse made by the SA node. The difference between sinus arrest and first degree or third degree SA block, that meaning that in this situation, we do have a nodal impulse formation. However, the charge is not getting out from this assay. Now, again, that's not an easy to diagnose. Basically, from the arrest or complete stop of the assay, especially when we are talking about the third degree assay block, because there is no P wave and only we do have a junctional escape rhythm. Now, in case of the first degree assay block, not the first degree, the second degree, but Mobius type or Mobius type 2, we have to evaluate the PP distance because normally the PP interval are constant. Here, however, is not. For example, looking at this charge, you do see a P here, but there's no P here, okay? And after you do have a P wave, and P wave, and P wave, and P. Now, what you have to do, basically, let's look at the last conducted piece and the first conducted piece, and looking at whether this twice as much or not, that's this when you do see the PP interval. If this distance is shorter than the last PP interval, it means Mobius type 1. If the distance are equal, that's called Mobius type 2. Do not worry because I do not think that during the midterm you will face this kind of ECGs. It's not an easy to diagnose. You have to have a good practice to diagnose this one. Okay, and you watch the movie, so you don't need to watch it right here. Now, as you see here, of course, assay block, the first degree is arrhythmic as well. And what we have to do that basically you have to looking at the PP interval and comparing that to this one. Okay. Second degree Mobius type 2. Very good. Okay, good. Go on. Now, the next big chunk of this conduction abnormalities, this is the bundle branch blocks. A lot of time you will face with these bundle branch blocks. And of course, you know that the bundles anatomically, that is when it's going from the bundle of His and very early, it's going to has a fascicles such as a right branch. And we do have another one that is septical fascicles. And we do, this is the left one, okay, this is all of them, it's a left bundle. And we do have the anterior and the posterior part of the left bundle branch. And of course, any of these fascicles can be blocked. So this is what we are talking about. For example, right bundle branch block, when the right bundle is not conducting. Usually we're talking about a third degree right bundle branch block because none of them is conducted. But sometimes it could happen that sometimes the QRS is normal, but sometimes gives you the right bundle branch picture, and that's meaning that's not a complete right bundle branch block. This kind of bundle branch block could be rate dependent, so heart rate dependent, because if the rate is fasting, relatively you do have less time for the repolarization, and the bundles are very sensitive to oxygenation, and usually this is what we are going to see immediately. The left bundle branch block, when we do have relatively, it's blocking the complete one, is blocking out completely everything, including the septal part and the anterior and posterior. But it could happen that this block occurs maybe only and affecting the anterior fascicles or the posterior fascicles. We're talking about bifascicular block. So far we had the right and the left can be anterior or posterior. These are the hemiblocks. We can have bifascicular when at least two fascicles are affected. The right bundle always included. So the right is out and or the left anterior or the posterior is blocked. We can have trifascicular block. Trifascicular block usually is meaning that we do have a right bundle branch block, we do have an anterior or posterior hemiblock, and we do have a first degree AV block. These are all caused by ischemia or infarction. This is what we have. Now let's go and summarize how the ventricle is activated normally. First of all, we learned that the septum is activated from the left bundle. All right, from the left bundle. If you are looking at, for example, here, this is the septal fascicle, the charge about 90% coming from the left bundles. All right, that's important. Okay, and that's give us a little positive wave, a little initial R in V1, and a negative wave, a Q wave on the left side in V6. Next one, the right and the left side activated simultaneously. However, because the left ventricle is about two and a half times thicker than the right one, and electric activity about 10 times higher than the right one, this is why the vector of the ventricle activation vector is pointing toward the left side. So this is why you do have a big R wave in the left side and the deep S wave on the right side. So what you do see here, an RS in the V1 and QR in the left side. Okay. Now, we do have another terminology, the intrinsicoid deflection or ventricle activation time is synonym, the same. Its meaning then from the beginning of the QRS complex till the last R wave, okay, or the biggest of the last R waves. This is different in each lead. This is why we should look at in right side and left side. Or right side is very, very teeny tiny one because this little initial R is only the septal activation. So it's less than 0.04 seconds, so it's meaning less than 1 millimeter. However, on the left side, because it's considering the top of the R wave, is less than 0.06 seconds. That's be important because whenever we do have a block, that those part of the ventricle activated later. So the left ventricle activation time is elongated, means we do have a left bundle branch block. If we do have the right side, the ventricle activation time elongated, that means we have a right bundle branch block. Okay, let's see what the right bundle branch block means. Okay, the first part of the septal activation is normal, so relatively we do have initial R wave in V1, we do have a Q wave in V6. The left ventricle activation is completely normal, fine, that's good. So the first part of the RS is okay, or the QR is okay. Now, what will happen with the right side? It's activated later and through the muscle. This is why we do have a wider part of this activation. It's meaning that we do have a wide R wave in V1 and a deep S wave on the left side. So this is why the pattern is RSR pattern, but sometimes it's not an RSR pattern, only a notched R. But as you see here, the ventricle activation time or the ID time is elongated on the right side and not influenced on the left side. Okay. I don't want to talk too much about the very simple one, very simple, and you can diagnose it by looking at, for example, the V1 or looking at the left side, lead number 1 or V6. You do see that very slurred and wide S wave on the left side and a tall R wave in V1, for example. Now, I haven't said anything about the complete and incomplete, only the matter of the width of the QRS complex. If the QRS complex is still in the normal range, this is called incomplete block. If it's wider than 0.1 second, that's called complete block, bundle branch block. Okay, yeah, this is what I said. Okay, now let's see the left bundle branch block. Septal activation influence. Yes, because a septum can be activated only from the right side. This is why you do have a S wave in V1 and the R wave starting in the left side. And of course, after we do have a impulse that goes from later on the right to the left. Sometimes you do see a little notching in this one because the right bundle activates the right ventricle, but sometimes you do see nothing. And of course, the left ventricle activation gives you a wide, big R wave on the left side and a deep S wave on the right side. So the left side, we do have a wide R and a negative or the S wave in the right side. As you see here, the ID time or the ventricle activation time is not altered because less than 1 millimeter. However, on the left side, yes, that has a pattern. It looks like as a M. Whenever you do have a block on that side, we do have this a notched R wave or M complex. This is why sometimes you can see some books that saying that William, for example, for the left bundle branch block. And if I go back to the right one, this is called Morrow because that should be an M and that should be a W. Oh, well, if you can recognize that a W. Okay, go on. Looks like everything that we do have a wide QRS looks like as a ventricle rhythm. But first of all, how can we judge whether it's ventricle rhythm or not? We do have P wave and we do have connection between P and the QRS complex. And of course, the ST segment is altered and that will cause some secondary ST changes. Any kind of muscle conduction is altering the repolarization phase, the STT segment. So you have to judge it. When we are talking about ischemia, you have to separate from the conduction abnormality altered STT segment or the ischemia caused STT alteration. Okay, anterior and posterior hemiblock. Now that's relatively, how can we diagnose? If we do have a hemiblock, the width of the QRS is not altered. However, what is altered? The electrical axis, the main electrical axis. This is why we are calculating the axis. Very simple. Anterior hemiblock will cause a extreme left deviation because the anterior part of this fascicle can be activated only from posterior. And the posterior fascicles is running from, let's see, to the right, to the left, and on the back of the ventricle. So this way, the all charge coming from the right to the left. This is why we do have a pathological left deviation. All right, looking at this one, 1 positive, AVF negative, 2 negative, that's a hemiblock, that's a extreme left deviation. The posterior, exactly the opposite, because the anterior gives us the charge toward the right side, so that will give us an extreme right deviation. That's it, period. Only looking at the axis, one is negative, immediately you can say that possible, that's a pathological right deviation, all right? You are not making a mistake. If you're looking at AVR, it's still negative, so it's between relatively 100 and 120, so it's less than 120, but possible that's a hemiblock, the sign of hemiblock. Now, when we're talking about bifascicular block, we do have the typical pattern of the right bundle branch block, okay? You do see that the ventricle activation time or the M complex occurs in the V1. Or sometimes you do see this kind of notching R waves in V1 or right side or V2. And the axis is extreme left deviated. So this is what we call as a bifascicular block. Okay, similarly, typical sign, as you see here in V1, typical sign of the right bundle branch block. The last sign, the last part of the S wave is very wide in lead number 1. Okay, good. So that's a right bundle branch block. And the axis, one is negative, so there's a posterior hemiblock. This is what is called bifascicular block. Good. Trifascicular block. The trifascicular block can be a lot of things. One thing, as already mentioned, that right bundle plus the left anterior hemiblock and the first degree AV block. Right bundle branch block together with the left posterior hemiblock and first degree AV block. Or both one is out, left posterior and anterior is out, and we do have a first degree AV block. Or we do have an alternating of the right bundle with the left bundle branch block. This can happen. So these are all called a trifascicular block, but the easiest to diagnose that we do have a right bundle branch block, hemiblock, and a first degree AV block. Okay, this is we will have in later on. But as you see here, yes, we do have a right bundle branch block. We do have a pathological left deviation, anterior hemiblock. And if you are looking at the PR interval, it's getting longer than 0.2 seconds. So this is why it's a trifascicular block. Okay. Now, rate-dependent right bundle branch block, as I mentioned, that when we do have tachycardia, the right bundle picture occurs. So this is not a complete right bundle branch block. That can be the high degree or uh, second degree, but it's called the rate-dependent right bundle branch block. Now, let's see something about the pre-excitation syndrome. The pre-excitation syndrome meaning that we do have a faster activation. Okay, we do have only one part when we do have a slowing down of the conduction, and that's the AV node. So we do have an accessory pathways, and that bypassing the AV node, and that can be a lot of things, but we do have only two types, the WPW syndrome or LGL. We do have the CAND bundle. This is a muscle type bundle that is connecting the atrial muscle to the ventricular muscle. And of course, the ventricle activation or a conduction is faster than an AV conduction. This is why the charge getting faster to the ventricle. And another one, the James fiber, when it's going from the atrial muscle to the bundle of His, directly to the bundle of His. This is being a different one, and that's give you a different ECG sign. Okay, let's see the WPW syndrome when we do have a CAND bundle. Fine, that's a muscle type bundle. What will happen? The SA activates the atrium. Good. That we do have the P wave. Now, the charge normally gets to the AV node or the bundle of CAN. But what will happen in the AV? We do have a slow conduction, all very slowly going on the conduction. However, a bundle of CAN, as a muscle type, immediately starts to activate the ventricular muscle. This is why that's a dotted line means that the AV conducting charge, and the blue one, that a muscle type conduction. What you do see, the PR is short. Right after the P, a ventricle activation starting. So the QRS is getting wider. And the first part of the QRS looks like as a delta wave, as you do have. So this is the sign of the WPW syndrome. Similar, simple one, PR is short, and we do have a wide QRS. PR is short, wide QRS, WPW syndrome. That is a really frequently occurring abnormality, and sometimes doesn't cause any problem, but sometimes it can cause some kind of paroxysmal tachycardia, or especially when we have flutter or fibrillation, that can kill the patient later on. So that could be very important one. Now, there are two types of this WPW syndrome depending on or the right side or left side. We do have this bundle of CAN. It can be anywhere. And of course, they will determine precisely because what they can do, one, nothing, another can catheterize, so they can remove or they can cut this bundle if the patient has some problem with it. How can we diagnose A type or B type? Look at V1. If it's a positive one, the delta start positively, that's an A type. If it start negatively, that's a B type. Looks like that's similar to the right bundle, that's an A type. And when we do have this left bundle, that's a B type. Okay, that's nothing else. Okay, so that's an A type, that's a B type, good. LGS syndrome, nothing at all, only what you do see, the PR is short and the QRS is narrow. That's it, LGS syndrome. Okay, pre-excitation syndrome, or that is meaning that can cause tachycardias. Now, we do have, we already discussed this one when we had a paroxysmal supraventricular tachycardia, nodal tachycardias. Now, very commonly, that's accessory pathways can cause tachycardia. This is what is called re-entry tachycardias or AVRT tachycardias. Now, AVRT tachycardias meaning that we do have this re-entry phenomenon that develops this in atrium and the ventricle, and of course, these accessory pathways can serve to maintain this impulse formation or impulse formation. Now, how can we differentiate between? First of all, if you apply, if you increase the vagal tone, carotis massage or Valsalva maneuver, this will stop immediately this kind of tachycardias. Patient will know it and they will stop immediately. Now, there are two types depending on the function of the bundle of Kent. If the bundle of Kent reuptaking the charge only, so the ventricle activated through the normal conducting pathways, this is called orthodromic AVRT tachycardias, so the QRS is completely narrow, or the antidromic one, this is called when we do have a wide QRS tachycardias because the ventricle activated through the muscles and AV junction reuptaking the charge only. So the AVRT is a narrow, orthodromic, or antidromic. This is what is called this AVRT tachycardias. For example, the orthodromic, as you see here, very narrow QRS, and you do have a wide QRS. This is called the antidromic AVRTs. Now is another one, when the nodal tachycardia, this is so-called AVNRT tachycardias, when this reentry developing inside the AV node or AV junction, and that's be very fast. And of course, this is paroxysmal, the reentry tachycardias, mostly paroxysmal tachycardias, and the involving only the AV nodal one, and very frequently can occur, and this is the most common cause of the regular supraventricular tachycardias. This is the AV and RT tachycardias. Okay, this is what I wanted to summarize this one. We have to decide whether this is a sinus or not. Okay, lead number 2, the P wave is positive and negative in AVR, and the same kind of P wave coming regularly. So this is a sinus rhythm. We said that is a regular one, period. Rate is around 80, 90, period. Axis was between 60 and 90, good. Now, so that's a sinus rhythm. Next one that you have to look at, but we haven't touched yet, but you should know the morphology of the P wave. That's normal. So the P should be less than 0.1 second and not taller than 2.5 millimeters. So that's okay. That's a sinus rhythm. Now you can talk about the PR distance because this rhythmic, it's meaning that every P followed by QRS. Now you can talk about blocks.
Okay, so the gap between the PR intervals is a around I think more than 5, if I have counted correctly.
Okay, this means 0.2, that means zero point 0.3, about 0.3 second, okay?
Yeah,
0.3 second, so that's longer than normal, but every P followed by QRS, so that means
it's first degree AV block.
correct. Okay, next, the QRS, how wide the QRS is? This narrow, yes, that's a normal width, okay? So we do not have any intraventricular conduction abnormality. This is what we can say today, all right?
Yes.
Good? Good. All right, let's clean it and let's look at who is the next one.
It's me. I have 103.
103, the best number. Okay, 103. Okay. Yes, listening.
So I don't know if I did it correctly, but I'll
Then
try.
you didn't never start an exam that I am not sure whether I know or not. No way. You have to sell yourself. Okay.
They're arithmetic,
Good. This is arrhythmic. Good. Go on.
and I calculated the heart rate from the most bottom one, 50 bit per minute.
Yeah, it's about 50, 60. It's okay. All right. Go on.
And then lead one is positive, AVF is positive, and lead two is also positive, AVR is negative, so maybe between 90 and 60 degrees.
Well, AVL is a little bit negative. So it means this is between 60 and less than 60. Okay. Okay. So it's more than 60. I'm sorry. More than 60. 60 and 90. Correct. Okay. Go on.
And if you look at the bottom one, the PR interval is getting longer.
We do P waves that coming regularly. Yes. We
Mm,
do see P wave, and that's P originated in the sinus because positive in lead number two, negative in AVR. But not every P followed by Q or S. Yes.
mm-hmm,
So we have some dropped P's.
mm-hmm.
What does it indicate?
I thought it's second degree AV block Mobitz type 1.
Because,
The PR interval is getting longer, and then suddenly there's a QRS complex not followed by it.
okay, now, by definition, and I urge you to use the following criteria. The last conducted PR, such as this, longer than a first conducted PR, right? Because if you had a, let's see, a long or a higher conduction rate, it meaning that the elongation is very teeny tiny one, so you could miss it. This is why the last one compared to the first one, this is what you should use all the time. Okay, last and the first.
Yep,
Good. Width of the QRS is normal. Yes.
yep.
Yep. Yep. Yep. Okay. Thank you. Next one.
Hello.
Okay.
I have a number 105.
Okay. Are you going to share it or I should share it?
If you can share it, thank
Yeah,
you.
that's fine. Okay.
Okay. So, first of all, I thought it's not rhythmic because we can see that every fourth we have a jump. We have an extra QRS complex. Um, so I thought it's not rhythmic.
Mm-hmm.
And as for the lead one, we see that it's positive. Also, the AVF lead two is positive as well, and AVL is negative.
Mm-hmm.
So it's between 60 and 90 degrees.
Mm-hmm.
Um, Two more things that we can see here that's why I wasn't exactly sure about. Yeah, we can see the P wave is quite constant except for the fourth QRS complex that is added. But also, if we look at V1 and V2 leads, we can see that they're negative, which points to WPW type
No, no,
B.
no, 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 no,
No?
no, 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 no.
Okay.
For diagnosing WPW, the PR should be short, and this PR is not short for sure.
Uh-huh.
Okay,
Okay.
so it's not. And in V1, that can be normal, this RSR pattern, it can be normal, or R, S, a little r, that can be normal. All right, that's completely normal. Now,
Okay.
let's
Perfect.
look at lead number two. It's
Mm-hmm.
meaning that not every P is conducted. Looks like here that every second is conducted, yes?
Mm-hmm.
However, however, if you had 2 to 1 AV block, that should be rhythmic, yes?
If I had 2 to 1, yeah.
It should be rhythmic because a PR is constant. The last PR, same as a first PR. Now let's see here. Here, especially, I think this is the unconducted one that is very bad.
Mm-hmm.
You can see it,
Doesn't
okay,
have a
this.
P. Yeah.
And if you are looking at the PR distance, that's getting longer. So the last one compared to the first one, that meaning that this is a second degree AV block, Mobius type 1. Okay.
Okay. Mm-hmm.
Now, as 2 to 1 can be Mobius type 1 or Mobius type 2. So possible this is Mobius type 1 and sometimes is 2 to 1 conduction occurring here. But after we do have a very clean second degree that showing the typical sign of Mobius type 1. All right?
Okay.
Good.
Perfect. Thank
And
you.
the QRS is narrow. Good. Period. All right. Okay. The next one is 108. Tian is here.
Oh, it's me. I have 107.
107. 107. Okay, I show you 107. It's right here. It's a nice one.
So I think the first part is I looked at the heart rate and it looks to be bradycardic because there's like
Mm-hmm.
6.5 blocks per
Mm-hmm.
RR
Yes.
interval, which is like around 45 to 50 beats per minute.
Mm-hmm.
I would say it's not sinus because every uh there's no QRS after every P.
That's a
So,
sinus rhythm. This is a sinus
oh,
rhythm. This is not a normal sinus rhythm. I can buy this one. But this is a sinus rhythm because in lead number 2 you have positive and AVR negative. It's true that the P wave is about the same. However, if I try to magnify this P wave, okay? We haven't practiced with this one, but it looks like this P is wide, yes, and nudged. Yes?
yes.
Okay, that's the type of atrial hypertrophy. This is the left atrial hypertrophy, P mitrale. We haven't practiced with this one. Okay, but
Okay.
it's here. So it's meaning that we do have a sinus rhythm. Okay, go on.
And then I looked at the heart's axis. So lead
Yep.
one is positive and AVF is negative. So that would be left axis deviation.
Mm-hmm.
So
So it's
around like
meaning
minus.
minus 30 and 0 between these two. So it's not an extreme left deviation, that's only a left deviation. Okay?
Yes. And then I looked at the P wave, which
Mm-hmm.
is the PR interval, which is constant throughout,
Mm-hmm.
which is around 0.2
Okay, doesn't matter
per.
how big the PR is here because not every P conducted. This is not conducted, conducted, not conducted, conducted, not conducted, conducted, not conducted, conducted, and it's rhythmically coming and the rate is rhythmic. So this is a
2:1 AV block.
2 to 1 AV block. Very good. Very good. Okay.
Yep.
Congratulations. Next one. Who has the next one? Come on. 108, 109, 111, Maria.
Yeah, I'm here.
Okay. So I'm going 111. Yes.
Yes.
Okay. It's your turn.
Okay, so first I looked at the heart rate and it's 75 beats per minute because we have four
Okay.
boxes. And then I looked at the rhythm and I would say it's a normal sinus rhythm because each
Mm-hmm.
is present before each QRS,
Mm-hmm.
and
Mm-hmm.
the QRS is upright in the second lead and it's negative in the AVR lead.
Mm-hmm.
So the heart rate is within normal range.
Mm-hmm.
And then I looked at the axis and I used the quadrant approach. And
Mm-hmm.
so we can see in lead one, it's positive, and in lead AVF, it's also positive. So it's also a normal axis.
Mm-hmm.
And then for the diagnosis, I think it's a first degree AV block because every P wave gets conducted, but very slowly. So the PR intervals are prolonged.
Mm-hmm.
And I would also say that we have an RSR
Because every
Uh, yeah, this is nothing. This is not a bundle branch block. Okay. This is not a bundle branch block. That's some kind of intramuscular conduction delay or changes, but it's not a right bundle branch block. For having a right bundle branch block, you have to have additional sign, and this should be here in V1. And V1, this RS pattern, that's completely normal. And however, it's possible because, but this is the left side, is not the right side. So maybe a little bit wider the S wave. So if you want to say maybe an incomplete block that we have, but I do not think that the right bundle branch block, because lead number 2 is about this M shape as well. So it can be maybe a incomplete left bundle branch block, but I don't think that this patient has this one. Okay, that's nothing.
okay.
It's enough with a first degree AV block. That was enough to diagnose it. Okay, that was 111. Taxon? No. 114? No. 119? No. Okay, 122, Omar?
Hello, Professor.
Yes. Okay, 122.
Yeah. Uh,
Great.
okay. At first glance, it looks fairly rhythmic.
This is rhythmic.
No, I mean not really because
That's a
the
barely
R,
rhythmic.
yeah,
Okay, it's not rhythmic. Not
yeah,
rhythmic.
because the
Okay.
RR values are different. I can't really
Okay.
see the boxes, so I couldn't really
No,
predict.
it's okay, but the rhythmicity, you
Yeah,
can judge the rhythmicity. Okay.
yeah. So then I looked at the axis of the heart, which was lead one is positive and AVF is also positive. So there's a
Hmm.
normal deviation,
Okay.
and
Normal.
I looked at the whether there's a sinus rhythm, and you can see there's P waves,
Where?
uh, and AVR
Where? Where is the P wave?
uh, just before QRS complexes.
This?
Yeah.
This is not a P. This is a T wave.
Oh, okay.
If you do have QRS complex, this is what I said. You have
Yeah.
to have T wave, okay? The
Mm-hmm.
P should be different. If you do not see P waves here,
Yeah.
you can say there is no P wave, all right?
Okay.
Because the
Okay.
P wave should be round, should be symmetric, and should be equal. But this is not. So we do not have P wave, okay? But
Okay.
this is arrhythmic without having any P wave. So what is your diagnosis?
Sinus
Cannot be sinus because you do not have P
block
waves.
oh atrial block
Fibrillation, atrial
fibrillation.
fibrillation. Okay,
Yeah. Mm-hmm.
keep in your mind arrhythmia, no P wave, atrial fibrillation. Immediately,
Mm-hmm.
don't hesitate, say it. It's much easier to say it than miss it.
Okay. Thank you.
So that means atrial fibrillation. Atrial fibrillation has a supraventricular impulse formation, so the atrium making the impulse and randomly conducted through the ventricle. Okay? Now we
Okay.
don't need to talk about P or PR interval. However, we have to talk about the QRS complex.
Uh, the QRS complex are fairly narrow.
This narrow.
Oh no, those ones they're not narrow.
This is not narrow either.
Mm-hmm.
Okay, so this is not narrow, this is wide. Okay, so it's meaning we have a supraventricular impulse formation, but the QRS is wide, so we have an intraventricular conduction abnormality. What kind of bundle branch block we have?
Uh, I'm not too sure.
Not too sure. Wide R complex in V1. This is the right side, okay?
Yeah.
And wide S wave on the left side. This is a right bundle branch block. Whenever you do have a wide R complex, the block is there. If you do have a wide R complex in V1, Right bundle branch block. If you do see the wide R complex on the left side, such as lead number 1 or V5, V6 or lead number 2, that's the left bundle branch block.
Okay.
Okay, and the axis was normal, so nothing else.
Okay.
Period. Okay, good. Go on 122, 123. Vatsala? No. Rabina? 126? Oh boy. Nihad? 127?
Yeah, I'm here.
Okay. 127. All right. Your turn.
So we see a rhythmic pattern. We can see five blocks between the QRS waves. So it's 60 hertz per minute. We see lead one is positive and AVF is B facing. So it's normal axis.
Mhm.
We can see also that is in the V1 that we having a left right bundle branch block.
This is a right bundle. Okay,
Right,
that's good.
yeah.
Right bundle branch block. Okay,
Mhm.
good. And you do see that the wider S wave in lead number 1 or V5, V6. So that's a simple right bundle branch block
Bundle
because
branch
there is
block.
no axis deviation. Period.
Mhm.
Very good.
Yeah.
Okay, 127, 128. Maria?
Hi, Professor.
Hi there. Okay, so that should be 128, yes?
28. Yeah.
Oh boy, interesting ECG.
Okay, I think it has a regular rhythm looking at the last one. And I calculated the heart rate and it was around 90 beat per minute.
Mm-hmm.
And for the axis, lead one is positive,
Mm-hmm.
but AVS I think is negative.
It's isoelectric one, that's it.
Okay, and 2 is positive, so I was thinking left deviation.
No, that's zero. That's it. Period. Zero.
All right.
It's
Okay.
still normal. It's still normal.
Okay.
Okay?
Okay.
Go on.
All right. And
P wave.
I think there is a P wave, so it's sinus rhythmic.
Mm-mm. Look at this piece. Okay, look at this piece. Negative in lead number 2 and positive in AVR. See?
Yeah.
What does it mean? What does it mean?
I'm not too
The
sure.
atrium, yes, you are sure. The atrium is activated exactly the opposite way. So that's the junctional escape rhythm or junctional acceleration because the rate was around 90, yes?
Yes.
And because you have exactly the opposite activation of the atrium. It's not a sinus activation for sure. So that's a junctional rhythm, okay?
Okay.
Next one
Um,
is the
I was
QRS is
thinking,
wide.
yes.
Okay, so
So I was thinking it's a WPW
no, no, no,
syndrome.
no, 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 no. PR should be short if you do have a WPW syndrome. This is the beginning until here. That's not short. That's normal, the PR, okay?
Okay.
So it cannot be a WPW syndrome. But again, why the QRS is wide? Because you have intraventricular conduction abnormalities. There are two things, right bundle bench block or left bundle bench block. Which one?
Um,
Where do you have the wide R complex?
in V1,
So that means
that means it's right.
bundle bench block. Exactly. That's a right bundle bench block.
Okay.
Because that side activated later, the right side, okay? The left
Okay.
side activation is okay, normal. Mhm.
Okay. Thank you.
Okay, 129.
That's me.
Okay, 129. Wow.
Oh, it's,
Yeah.
yeah, 129, my bad. Yeah. So from first glance, this appears to be a arrhythmic.
Good.
Now I didn't actually calculate the heart rate, but I could do it now. Just
Okay,
go.
the heart rate could be normal. All right. So it's
Yeah.
not tachycardic nor bradycardic, but maybe a little bit bradycardic, I would say. But okay, good.
And also just like quick, like from first glance, there seems to be an atrial flutter.
No, 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 no. Okay, by looking at V1, it looks like that an atrial flutter because you do see this some kind of undulatory wave. Okay, here.
Okay. Yeah, yeah.
However, look at the rate.
Okay.
This is more than 350.
Okay.
See? It's less than one square. If you had one square, it means 300, but this is faster than 300.
Okay.
And the flutter should be less than 300. If it's faster, that meaning we do have a
Relation.
exactly. So that's an atrial fibrillation. Very good. And
So
this is arrhythmic, very nicely. Okay, go on.
so even so like if you see like the seesaw waves, you should still try and decide on the and like
Rate,
on the
exactly.
rate.
You have to look at the rate of the atrium because by
Okay.
this high rate is no way that this fully contracting the atrium. Okay, go on.
Okay. And then also just from first glances, there is the widened S waves in V
Wide and QRS complex.
widened QRS complex, and also the S wave is slurred in the V5.
That's ST segment is altered, but this is a wide R wave
Right.
in V5, V6. Okay,
So the
that's a secondary
intraventricular
ST changes.
uh,
Okay, so
intraventricular conduction abnormality.
which one?
For this one, so it's widened QRS. There is no P waves.
This
Um,
is AFib. That's fine.
okay. Which
Plus,
plus the intra oh the V1 is negative, so it's a left bundle branch block.
yes.
Okay.
Okay, and the X is positive. EVF, it's
Right,
about
so
zero, so it's around
zero. It's
0 degrees.
just normal. And just a quick question as well.
Mhm.
So you pointed out at the V1, I think, like you showed as well that that was characteristic for a left bundle branch block. But what
Mhm.
else did you look at in order to just make sure that you know?
V1, this is
Yeah.
the right side all the time, right side and the left side. Left side can be lead number one or V5, V6.
Okay, and was it also because you saw like if it's a widened QRS complex plus this negative RS complex in V1, is that always going to be a left bundle branch block?
If you do have a QS complex, yes.
Okay. But if there was a narrow QRS in the V4, then no? Or
This is not narrow
but if
because
there was,
from the beginning till here, that's
okay,
wide.
just theoretically, I mean, if there was,
If you had a narrow QRS, but you
yeah,
do have a QS complex in V1 and a nudged R wave in V5, V6 or lead number one, that can be an incomplete left bundle branch block.
okay, okay,
Okay.
perfect. All right, then. Thank you.
You're welcome. Okay, that was 129. Okay, oops. Wait a minute. All right. 130. Alvin? No. 133. Sayed?
Hey, hi.
Okay, good. Wait a minute.
Okay.
123.
I think it's rhythmic.
Okay.
The lead one is positive. Lead
Mm-hmm.
AVF is negative. Lead two is negative, and AVR is positive. So it's somewhere between minus 60 and minus 90.
Mm-hmm.
The QRS in V1 is wide, and
Mm-hmm.
the S wave is slurred in lead one, AVL, V5, and V6.
Yeah, but what about the P wave? Do we have P waves?
Yep, I'm
Well,
seeing it in lead one.
okay. This is a P. This is a P. This is a P. Okay. Here.
Oh, sorry, I was doing 133.
Oh, one, two. I'm sorry.
Oh, yeah.
Okay.
Okay.
Oh, good.
Uh,
That's the different one. Okay, good. Now it's better. All right. So that's
yeah,
rhythmic. Okay, good. And we do have sinus P wave. Okay. QRS is wide.
yes. And
Okay.
it's the S wave is slurred in V5 and V6. So I'm guessing it's right bundle branch block.
Okay. So we have so far that's a right bundle bench block, and you do see this. Okay. So far this is right bundle branch block. Okay, good. And
And
and lead number one is positive. AVF is negative. Lead number
yes,
two is
negative.
negative. EVR, well, it's equiphasic,
Yes.
meaning
It's a left deviation.
that's a extreme left deviation, meaning that you are between minus 60 and minus 90 or
Mm-hmm.
close to minus 60 because this is what perpendicular to AVR. Okay.
Mm-hmm.
And what does it mean when we do have an extreme left deviation?
Left bundle branch block.
Nope,
Two.
this is not a left bundle. You said right bundle bench block. That's what it correct. However,
Oh, I'm not sure.
yes, you are sure. That's a hemiblock.
Yes.
We do have a left anterior hemiblock.
Yes.
And this together called?
Uh, try something.
No, that's by something because it's two. One, the right bundle, and another one is a left anterior hemiblock. So that's a bifascicular block.
Yes.
Okay, so that's a bifascicular block. Okay.
Okay.
If you have a trifascicular block, the difference is the PR interval should be longer, and that should be the trifascicular block. But this is only a bifascicular block. Okay, 135. Nobody is here, so let's look at 135. Okay. Now, what do we think? Who wants to solve this problem? I think you can do it, Sayed or Mahmoud. Very similar to yours. Yes? Huh? Oh,
Is
it's tough. Yes,
uh
okay.
this is Cheyenne, by the way.
Yes, Sharon, yes, I can see it when we are talking.
Yeah, for this one, is there so the rhythm is regular.
Good.
This one, you have widened QRS complexes.
Mm-hmm.
So there's an intraventricular abnormality,
Mm-hmm.
and also in the V1 there's the elongated S wave. So
V1 is not S wave, that's a wide R wave, okay?
what R wave? Uh,
Okay. And the negative T wave that you have, it's okay.
oh, that's the T wave. Oh, okay, okay. I thought that was the S wave. Okay, so that's
Mm-hmm.
so yeah, you have a widened R wave, but you have um, you don't have any P waves before.
We do have P waves.
Okay, so then okay, so there's no block in the atrioventricular conduction.
Yeah, we do, because that's longer than zero point 0.2 seconds.
Um,
So we do have a first degree AV block because
just
every P conducted but slower than normally. We do
oh,
have a wide QRS complex, and it looks like this is a right bundle branch block. We do see
and
this M
oh,
complex in V1.
and
Okay.
Marie.
Plus, we have a first degree AV block. Okay, fine. Plus, what about the axis?
Okay, oh yeah, so we have a we have a negative or a negative first lead, and then
Hmm.
AVF is also negative.
Okay,
So
so
there's an extreme deviation. So extreme left.
AVR is positive. So,
There's an extreme left deviation.
okay, that's an extreme left deviation. Okay, it's meaning that
There's a
minus 60 to minus 90. Okay.
yep,
And
um,
this is a
tricuspic
Trifascicular block.
Trifascicular.
Trifascicular block because we do have an extreme left, that meaning left anterior hemiblock, first degree AV block, and a right bundle branch block.
Okay.
Okay? This
Yes.
is what we have.
For sure.
Oh, okay, good, very good.
And just
All
sorry,
right.
one more question. So if you see a widened QRS in V1, you assume that there's a right bundle branch, right?
No,
No?
no. The QRS is wide everywhere, except when you do have a wide R wave in V1, a
Oh, the
notched
R
R
wave.
wave in V1. That's right bundle branch block.
Oh, okay, okay.
You have a QS complex in V1, that's left bundle branch block. And you do see a wide nudged R wave on the left side. That
Yeah.
means left bundle branch block, okay?
Okay.
That's a different.
Okay.
It looks like when you do have a right one, you do see this kind of complex on the right side. If you do have a left one, you see this one on the left side.
Okay. 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 I see.
Okay,
Yes.
good.
Thank
All
you.
right.